Okay, we're going to start talking about Chapter 4 now. Chapter 4. As we know, based on looking at just conventional radiography, there are several limitations of it. And because of these limitations, we have to compensate. First, it was compensating by using different methods to acquire images, and now it has become basically the standard protocol that CT has kind of filled in the gaps for when we cannot see things on conventional radiography. So the first thing that we have to worry about with conventional radiography is quite simple. Quite simple. The first thing is superimposition. We know that because everything appears in just a flat image on a screen, that there tends to be a lot of superimposition. And so basically you have superimposition of all of the structures on the film, which makes it sometimes difficult or next to impossible to distinguish a particular detail. Where is this calcification located? Is this located in this one specific portion of the anatomy or somewhere else? Also, you can't see specific trauma sometimes, or the location of such trauma items. For example, if you have a gunshot wound and you see an entry and exit, let's rephrase that. You see an entry point, but you don't see an exit point. And so you shoot just a conventional radiograph. Basically, all you're going to see is, if you only take one view, is just that this item is in there. You can't really tell where it is because of the superimposition. And so we also see that when structures only differ slightly in density, as is often the case with some tumors and their surrounding tissues, you really can't detect them. We all know that to be true. Colon cancer necessarily would not show up on just plain film radiography. Also, uterine cancer would. Things like this. We do know that lung cancer shows up very well in the lungs when you shoot a chest X-ray, but that's a total different ballgame. When the tumors differ very slightly in the density from the surrounding subjects, you cannot see them. Although multiple views such as laterals and obliques can be taken to localize a structure, the problem of superimposition in radiography still persists. The question becomes then, how can you really locate an object? Sure, you can take laterals, obliques, and you can get a close idea of where things are, but you still can't get a full idea of where a structure's location is. A second limitation is that radiography is a qualitative rather than quantitative process. So basically, what we say here is that it's difficult to distinguish between a homogeneous object of uniform thickness and heterogeneous objects such as bone, hair, soft tissue of a uniform thickness. And so basically, it's difficult to distinguish between something that is just made out of one thing versus something that is made out of many different things. And we see that with radiography. You really can't distinguish parts of the colon based on just conventional radiography. Things like this become very, very limiting. And that's why we see that there had been developments to try and get around this. And so this brought about conventional tomography, not CT per se, but just tomography in general. That's what spurred the conventional radiography limitation, spurred a tomography to be developed. And we see that the immediate goal of tomography is to eliminate structures above and below the focus section or the focal plane. And so basically, you want one specific area, and you just want the anatomy in this specific area, and you want to discard above and below, so you can focus on this one plane. And so because of this, tomography yielded some excellent results. The limitations of tomography, though, include persistent image blurring that cannot be completely removed. So no matter how hard you try, there's always going to be some degrading image blurring. Degradation of image contrast because of the presence of scattered radiation created by the open geometry of the X-ray beam, and other problems resulting from film screen combinations. So while tomography did have benefits, it did have a lot of limitations as well. In addition, both radiography and tomography fail to adequately demonstrate slight differences in subject contrast, which are characteristic of soft tissue. So the one thing that both X-rays and tomography have in common is this, that they really can't distinguish abnormalities in structures that have very similar densities. So that is a flaw for both. Also, radiographic film is not sensitive enough to resolve all these small differences because typical film screen combinations used today can only discriminate X-ray intensity differences of 5 to 10%. And so while this is talking about film, it also applies for what we are doing today with digital radiographic acquisitions. Basically, that we cannot distinguish lower than around 5% density differences. And so we all know that it works really well for analyzing bones and things like that. But when you get into the small minor differences, we can't still distinguish them. And so that is the reason why tomography still did not catch on. And so here we see basically X-ray, and here we see CT. And so notice here with analyzing basically a skull and somewhat of facial bones, excluding most of the maxillary and the mandible, we see that we get pretty much a static image where we can possibly manipulate the window and contrast levels, but what information is on the image is what is always going to be. And so you can lighten and darken to bring out certain points of the anatomy, but still you're limited. Also notice that you cannot see the brain inside of this area. And so you have all of the bony anatomy, and you might be able to rule out a fracture, things like that. But you cannot tell if there's actually trauma inside of the head. And so that's where CT does an excellent job. Notice we can see both the cranium and we can see what's inside the cranium here. And so that's very important. But also what we can do is we can throw up 3D reconstructions and demonstrate all of the facial bones to a higher degree than what the X-ray could ever demonstrate. And then also have the ability to oblique, to turn it sagittally, to look straight ahead in an AP view. All of this stuff is what makes CT just that much better. Also, we see that we have chest X-ray here, and notice that we can see some of the lung markings. We can see the clavicle, we can see the ribs, the heart, the trachea, but we can't see any more detail than that. So if we scan this patient, we can see now that we have the sternum, the ribs, we have the heart, and the left atrium here coming in, the pulmonary veins, and then we see that we have this area here, which possibly might not have been present on conventional X-ray. Also, we do have a chance to see the aorta, and then when we manipulate it into a coronal image, we can see other anatomy. We can see the pulmonary arteries here. Looks like there's something going on there. And so basically, as you can see, computer tomography has allowed us to view patients to a higher degree and has really increased the amount of information that we have that can lead to a potential diagnosis for the patient. So one thing that we always hear about, always is in the back of our mind, is that there's an increased dosage with CT. But the thing that you have to realize is that the benefits that you get from doing a CT most of the time will far outweigh what you may actually be doing in terms of damaging the patient. So here we see basically, I guess you would call this a KUB without being able to really differentiate where the kidneys are. We're up to about T12, T11, and so that would suffice for a KUB. And we have stomach air here, a little bit of air, and probably the cecum or ascending colon. We can see the bony anatomy, and we can catch a rib or two coming in, but pretty much that's all we can do. KUBs really are kind of up in the air about what you may see or what you may not. And we also know that we can see sometimes the outline of the kidneys and the liver borders and things like that, but grossly it's inefficient because you really can't see anything else that's going on. If we change over to computer tomography, we can now see the aorta, the liver in its entirety, the spleen, all of the intestines and ribs as well, and even the musculature. And then if we manipulate it into a 3D reformatted image, we can see the aorta, see if there's abnormalities here. We can see the kidneys. And so just a higher degree of differentiation in terms of CT versus all the other modalities. And so that's why conventional radiography in many cases has lost a lot of ground to CT. So this image is kind of basically out of position, but this is what tomography is. So if you want to write on it, tomography, that's what we're actually looking at here. I don't know how many people have actually performed tomography, just conventional tomography, but this is what tomography would actually look like. You have the X-ray tube up above, and the X-ray tube goes back and forth, and you have film that varies in location. So the film is tied to the tube, and so when the tube moves one way, the film moves the opposite way. You have the patient here. And basically, this area here, or the fulcrum, is where the X-ray tube and the film kind of pivot on, and you want it in the center of what anatomy it is that you're wanting to view. And so, as you can see here, the problem with this is everyone's anatomy is different. And so how can you guarantee that on the first try you're actually going to get it? So that would mean that multiple times you would probably have to shoot this image to see if you can actually acquire what you're shooting for and what you're striving for. So sometimes this is up in the air, and you can imagine that if you were utilizing contrast, it would be very important that you got this right on the first time. And so there are a lot of variables with just traditional tomography that have to be overcome to make it effective. And that's one of the many benefits of CT, is that CT is really not operator dependent as much as it is just being able to perform the protocols. If you can carry out these protocols, then technically each person that walks into the CT suite to perform a scan on a patient should be able to yield the exact same results, simply because of established protocols and a lack of variance in terms of the ability to perform exams. So that brings us to CT. And so a lot of times it kind of gets discounted, but the overall goal of CT is to overcome the limitation of radiography and tomography by achieving the following. So you want to star these. You will see these on an exam. Number one, minimal superimposition. So we don't have a lot of overlap because we see things in a different way. We see everything, not just one little specific part. Improved image contrast. Basically, 2 and 3 kind of go together. Because of improved image contrast, we have the ability to record very small differences in tissue contrast. And so, while we established the fact that in conventional radiography you might not be able to see a tumor, that's not the case for computer tomography. Tomography pretty much will allow you to see every little bitty density difference. We've decreased the amount or the amount of difference that has to be in tissue to actually be able to be seen by CT. And because of that, we can see all of these little tumors. We can aid in diagnostic value clear across the board. And so it's very important here that CT has met or is achieving these goals. And without these goals, CT would just be irrelevant and there would be no need to perform it. So I'm sure we all have grasped the concept now, but in terms of CT, we have the X-ray tube, and we have a detector on the other end. And the detector takes the X-ray photons and turns them into a manipulative image. Well, the detector and the computer work cohesively to basically transform these X-ray photons into readings, which the computer can use to generate an image from. It's quite amazing, actually. And so that brings us to this one important part, data acquisition. We have to get a grasp of what data acquisition is before we can truly understand all of the things that go into it. So data acquisition refers to the systematic collection of information from the patient to produce the CT image. And so basically data acquisition is how this information is collected. There's two methods of data acquisition, and we saw that before: slice by slice data acquisition or volume data acquisition. Based on new technology, everything has tended to gravitate more towards volume data acquisition because of many benefits: the speed in which it's acquired, the amount of images that can be reconstructed, such as mp4s and 3D volume, VIP, things like this. And so typically we're seeing that volume data acquisition is the most apparent now. In conventional slice-by-slice data acquisition, you may have actually, depending on how long you've been utilizing CT, you may have seen conventional slice-by-slice data acquisition, or you may never have. The first scanners basically operated in this manner, and there's still some argument that this type of scan yields a better result for CT heads than your volume or helical path. And the argument is that it decreases the amount of image artifacts, things like that. But there has been a growing push to utilize volume scanning for pretty much everything, just based on the amount of manipulation and reconstruction techniques that can be employed utilizing it. And so basically, in conventional slice by slice, you have the X-ray tube rotating around the patient and then collecting data from the first slice. And so once that first slice is acquired, let's draw an image of a patient's head here. And so let's say that we start here. This will be slice number 1. And then after slice number 1, the tube is going to stop rotating. The patient table is going to move to the next location of the slice, and then we're going to have another scan. And it's going to keep doing this, stopping, patient table moving, and then scan, patient, the tube stopping, patient table moving, scan with the tube moving until all the slices have been individually scanned. The key word here is individually. And so there is not this one constant motion of the patient table moving plus the tube continuing to move, but each slice is acquired individually, and pretty much it'll take a longer point in time to do this. Now, the problem with conventional slice-by-slice data acquisition is this. Time. It really doesn't cross your mind until you actually get a patient that will not cooperate. And then when you have a patient that will not cooperate, time seems to stand still in the CT suite, especially if you're by yourself. Basically, slice by slice gives the patient enough time to move in between the slices and really mess up the scan. And so that is why there is a huge shift to volume or helical slice acquisition. I'll tell you an example of the growing dependency on helical scanning. One night through the ER, I was having to do a rib series, just conventional radiography on a patient, and so he'd fell and was having trouble breathing, and then later had a headache. But I shot the ribs, took the patient back, and probably about an hour later, the ER physician decides that he would like a CT of the head. And so our facility was still utilizing conventional slice-by-slice data acquisition. We did have on our protocols a quick head, which utilized helical, but the accepted protocol at the time was to use slice-by-slice data acquisition. However, for facial bones and all of that, we were utilizing volume reconstruction. And some of my colleagues and I, we were getting really fancy utilizing all these 3D images, and the physicians were beginning to expect that. However, we had done it a couple times on the head using our trauma or quick head series. But typically on most patients, we were utilizing just the slice-by-slice method. And so I scanned the patient utilizing the slice-by-slice method. And the problem with slice-by-slice is that when you go to recon it, you have these little things like this. Not like this. And so it has a stair-step pattern, and it looks like you're missing information here and here and here. Okay, and I'm sure that you've seen it before. And so I take the patient back over, and typically we didn't do coronals or sagittals. We just did axials and bone windows on axials, and that was it. And the ER physician calls over probably about 30 to 40 minutes after I'd already scanned the patient. The images had been sent over to PACS. And he asked if we can do 3D recons. And so I say that I really can't do that based on the type of scan that I actually performed. To do 3D reconstructions, I would have to take the patient back, scan them again, and pretty much manipulate those images and discard what I've already done. And so the ER physician's reaction was, okay, go ahead and do that. And so I had to bring the patient back over, scan them again in a helical fashion, and then reconstruct those images as well. And so to make a long story short, that kind of spurred us on to utilizing helical scanning, and we really haven't looked back since. So every patient comes in, whether trauma or not, gets a helical scan of the head when a head CT is ordered. And so many times the slice-by-slice method, just the time-consuming portion of it, really factors in, and that's why it's really not utilized very much any longer. In volume data acquisition, we see that a special beam geometry referred to as spiral or helical geometry is used. We saw that it's this pathway. The X-ray tube rotates around the patient and traces a spiral or helical path to scan an entire volume of tissue while the patient holds a single breath. This method generates a single slice for one revolution of the X-ray tube. It is often referred to as a single slice spiral helical CT. It's not supposed to be GT. This is supposed to be CT. Multi-slice or spiral helical CT has become available for faster imaging of patients. And so, once again, we see that the issue of time is vastly important. And with spiral or volume data acquisition, we see that time has really decreased. And so that is what we have strived for, and it really has come into fruition here recently. We've seen a growing shift to utilizing CT to a higher degree. Multi-slice CT scanners generate multiple slices per one revolution of the X-ray tube. For example, multi-slice CT scanners can now generate 4, 8, 16, 32, 40, 64 slices, 256, and even 320. While we don't really see 320 slices right now, but over the course of time we will see it become more common. But we do see 40 and 60 slices and even 16 slices utilized to a high degree. The first step in data acquisition then is scanning. So step number 1, scanning. Put a star beside that. This is when the X-ray tube and detectors rotate around the patient, and then X-ray photons are emitted, and the detectors measure attenuation values. So this is very important that the X-ray detectors or the CT detectors measure attenuation values. Without this measurement, then CT becomes null and void because you're emitting X-ray photons without having the ability to actually determine what is going on with them. And so we see this being pretty much what happens. Also, this is third gen in terms of scanning based on the detectors. But we see fan beam or the cone beam. Basically, the photons are being emitted through the patient. Some scatter is going on, and ultimately the detectors are catching all of the radiation. And so the detectors acquire what is coming from the patient, measure it, and then utilize these attenuation readings. They come up with these attenuation readings, and they are then sent to the computer, where the computer takes these attenuation readings and then plugs them in and makes them a manipulable image. So an important formula to remember is this. We're not going to do any calculations or anything like that, but you need the logarithm of the intensity of X-rays at the source, which is spelled like this, not like that, divided by the intensity of X-rays at the detector. And so you don't really have to know a whole lot about this equation. The only thing I really want you to understand is that there has to be measures of the X-rays at the source, and there has to be measurements of the X-rays at the detector. And so basically, if you take you disregard this log for a second, and you take the X-rays at the source divided by the X-rays at the detector, basically you're going to get some type of number. You can't have more X-rays at the detector than at the source, and so you're going to get usually a whole number, and then you take the logarithm of that. And so that's very important. Basically, the only thing I really expect you to remember from this slide is that you have to take a measurement of the X-rays at the source and at the detector. Both of these measurements are very important. So then the relative transmission values are sent to the computer and stored as raw data. And so that's another thing to keep in mind. It's not data that has been formatted, but it's raw data. And so a large number of transmission measurements are needed to reconstruct the CT image. In general, several hundred views are obtained. And so there's going to be a lot of transmission data stored in the computer that the computer has to do fast calculations on, so that we can acquire or that we can see an image. So the problem in CT is to determine the attenuation of the tissues and uses this information to reconstruct an image of the slice of tissue. So basically, one important thing that I'm sure that we apply to conventional radiography, but many times it's disregarded, different tissues affect how the image looks. And I think that's something that we would all agree to. That bone will show up as white, and air will show up in conventional radiography as basically black or some form of gray. So with that being in mind, we know that different tissues look different. And so that has to apply with CT as well. And you have to determine what type of tissues are based on the amount of attenuation or the amount of X-ray photons that they remove from the beam. And so it's important for us to remember attenuation. So to start by this, attenuation is the reduction of the intensity of a beam of radiation as it passes through an object. Some photons are absorbed, but others are scattered. And so that's important to keep in mind, that you're going to lose photons. Some photons are going to be absorbed by the patient, others are going to be scattered. And so based on this, it's very important that we have accurate readings so that we can demonstrate whether something is or not in the patient. And we see that it depends on the electrons per gram, atomic number, tissue density, radiation energy used. So attenuation depends on all of these things. Put a star by it, keep that in mind, that all of these things are something that affect attenuation in the patient. The book kind of gets a little confusing because it gives you two separate lists of things that attenuation in CT depends on. We'll see that the previous list has electrons per gram, atomic number, tissue density, and radiation energy used. And basically, this is much the same. So pretty much compile the two lists and just know that all of these things are attenuating factors in terms of CT. And so we see that the effective atomic density, or atoms per volume, will really affect what is going to be attenuated and what's going to pass through the patient. The atomic number of the absorber. And so we all know this to be true, that as you go up the periodic table, or go down, I guess you would say, to be more correct, and the Z number increases, you're going to have a greater amount of attenuation. And so we all see that just embodied in our just daily life in terms of radiography, in that if you x-ray someone who has a belt buckle on, you forget to remove their belt buckle, and they have this big huge belt buckle, and you shoot just a conventional KUB on this person, then basically you're going to see this big white object, and it's going to be even more dense than the bone of the patient, and it's going to basically have attenuated more X-ray photons than the bone did, than the air did, all of the other structures in the pelvic area. And so, as we know, the material that this belt buckle was made out of has a very high Z number, and because of that, it's going to have attenuated more X-ray photons than the other things in the image. Also, the photon energy, how much energy is behind these photons, will actually affect how much attenuation is demonstrated. We saw on our previous lecture that this is remedied by a filter, which seeks out to remove the long wavelength radiation that will potentially just contribute to patient dosage and nothing more. So there's two types of beams, and we want only one of them. A homogeneous beam or a monochromatic beam means that all photons have the same energy. A heterogeneous beam or a polychromatic beam means that all the photons have different energies. We have this type, but we want this type. So we're going to write here, this is what we want. We want the homogeneous beam simply because if we have something that everything has all equal values, it makes things a lot easier to calculate what the attenuation factors are. It's kind of like if each of you had an examination and I put different amounts of questions on each one of your exams. It would be very inaccurate for me to try and determine who is the best student at CT physics when I've structured the exams to be very different, and some may cater to someone while another one may be the complete antithesis of what you want. And so it's very hard, it'd be very hard to actually get an accurate reading based on that because the tables would be skewed. And so that is very similar to what we have here. If we have all different energies, it'd be very difficult to ascertain which is being attenuated and which is just simply not even having the ability to make it to the patient. And so that's why we have a filter. So the attenuation of a homogeneous beam of radiation, each section of the absorber attenuates the beam by equal amounts. That is, each 1 centimeter section removes 20% of the photons remaining in the beam. The initial beam intensity of 1,000 photons is reduced to 410 photons based on one certain image. And so let's do some math here. So if we do math, we see that, and we begin with (1,000) photons. And we go through 1 centimeter of tissue. We reduce it down to 800. We reduce 800 by going through another centimeter of tissue. We've got 640. We reduce that by going through another centimeter of tissue. We come up with 512. We reduce that by going through one more centimeter of tissue. Then we get 410. And so basically, we can go through 4 centimeters of tissue and we reduce the quantity of photons. That becomes very important. We lose quantity. But the important thing to do is to think about is this, that I'm putting a star beside. In a homogeneous beam, the quality does not change. The beam energy does not change. The 410 photons that still exist after 4 centimeters of tissue still have the same penetrating power to make that all of them pretty much have the same penetrating power. I guess that's the easiest thing to say. If the starting beam energy is 88 kilo electron volts or keV, the transmitted photons all have the energy of 88 keV. And so basically the beam energy is not going to change, and they all have the same energy. Okay, a conventional X-ray tube, not tub, but this is supposed to have an E here, produces a heterogeneous beam. And so that's something to keep in mind. When you think about an X-ray tube, you're looking at a heterogeneous beam. As the beam passes through equal thicknesses of material, the attenuation is not exponential, but rather both the quantity and the quality of the photons change. So where we saw that only the quantity changes on a homogeneous beam, on a heterogeneous beam, both the quantity and the quality changes. Very important to keep in mind. X-rays can be attenuated because of the photoelectric effect and the Compton effect. And we won't necessarily go into these right now. The photoelectric effect and the Compton effect. The photoelectric effect occurs mainly in tissues with a high atomic number. So keep that in mind. Your Z number is going to basically affect what occurs in the photoelectric effect. And it occurs mostly in bone or contrasted mediums, and occurs minimally in soft tissues and substances with a lower atomic number. So keep that in mind. It's going to occur in bone and some of your contrast mediums. In addition to the photoelectric effect, depends on the beam energy. Depends only on the beam energy, pretty much. The Compton effect occurs in soft tissues. Differences in density result in differences in the Compton interactions. So the only thing that you really need to keep in mind is the photoelectric effect, which we'll say is PE, occurs in photoelectric effect occurs in high atomic numbers, whereas the Compton occurs in low atomic numbers. So that's virtually the only thing that you really need to keep in mind in terms of the interactions here. So data acquisition geometries. Data acquisition geometries is the way that the X-ray tube and the detectors are arranged. We see that there are two types. One being the X-ray tube and the detectors are coupled and rotate 360 degrees around the patient. And so we know this to be third generation. The other type is the tube is placed in a stationary ring of detectors and rotates 360 degrees around the patient. We know this to be fourth generation. For the most part, third generation is the most common type. The key thing is that both types use a fan beam. So regardless of what generation, be it third or fourth, they both use a fan beam. So there are some steps in the data process. How do you actually get this data that you've acquired and make it into something that is actually usable in terms of CT? Well, the first step is that the raw data, that's basically your data that's received from the detectors. And so we saw before that the detectors acquire the data, then transmit to the computers. It's pre-processed. This is where corrections are made and types of filters can be applied. So, pre-processing. Then we have image reconstruction. The scan data is converted into a digital image. So, it's important to remember that there's a difference between a digital image and basically an analog or a true type of image. The digital image is what you're going to see on monitors or packs. And so basically it's because of the way that we basically look at images and transmit images that everyone usually looks at a digital image now. to from your radiologist to other physicians to even you as a tech look at digital images. Then that brings us to the third step, which is image display and storage. And so the digital image is displayed on monitors, but also one thing that's kind of went by the wayside, but sometimes it's still carried out, is printing the images. And so when you print, the image is no longer a digital image. It's actually on a piece of film, and so that drastically changes things. And then, how do you store these? What methods are you going to use to maintain these images and keep them around so that they don't just basically fall off and never be able to be accessed again? Going back to a digital image, the great thing about digital images versus printing is the fact that digital images can be modified. If you want to specifically look at some type of anatomy, then you can window and level the image so that you can best demonstrate this piece of anatomy. That's very important because in terms of printing an image off and it being on film, it's a very static image and there's nothing else that you can do once it's on this image or once it's on the film. So that brings us to this important part, CT numbers. Each pixel in the reconstructed image is assigned a CT number. So every pixel has a number. CT numbers are related to the linear coefficients of the tissues that comprise the slice. In the first EMI scanner, the value of K was 500, which resulted in a contrast scale of 0.2% per CT number. The really important thing that you need to remember here is the value of K was 500. Later, the contrast factor was doubled, giving it a factor of 1,000. Numbers obtained this way are on the Hounsfield scale. So the Hounsfield scale has several numbers. You have plus 1,000, you have 0, and then you have a negative 1,000. And so usually we say that the numbers fall somewhere in this area. 0, which is equal distance between both a negative 1,000 and positive 1,000, is where water resides. That is the density of water, 0. The number for bone is plus 1,000. And so basically we can say that plus 1,000 is more dense. And negative 1,000 is air. And so we can say negative 1,000 is less dense. The computer calculates the CT numbers, which can be printed as a numerical image. While we could print out a huge matrix of numbers and it would look pretty amazing to see all these numbers on a sheet of paper, but it wouldn't do much for the patient. It would do little to diagnose, actually nothing at all, because there would be no way that you could somehow in your mind wrap it around how to utilize these CT numbers. So it must be converted into a digital image. And as we'll see, the numerical sheet would be a little bit staggering, and it's kind of amazing just to look and see how CT actually converts this. To accomplish this, the conversion brightness levels were developed to be represented by these numbers. Plus 1,000 equals white, and negative 1,000 equals black. And so this is why air appears black and why bone appears white. And so basically you associate plus 1,000 with being white, being more dense, such as bone, and negative 1,000 being black or less dense, and just like air is. So We also see that photon energy also affects CT numbers. In the original CT scanner, CT numbers were calculated on the basis of 73 kiloelectron volts, which is the effective energy of a peak of 230 peak kilovolt beam after passing through 27 centimeters of water. Thus, the CT number for water is 0, and the CT number for bone is 1000. In CT, a high kilovolt technique, about 120 kV, is generally used for the following reasons. So basically, the reason we use around 120 kV is this: to reduce the dependence of attenuation coefficients on photon energy, to reduce the contrast of bone relative to soft tissue, and to produce a high radiation flux at the detectors. And so basically, we want to allow a wide range of contrast. When we say reduce the contrast, we mean that we pretty much widen the amount of grays that are demonstrated, so there's just not this steep drop off between black and white, or black or white and gray, but there's several different areas there. And also to produce a high radiation flux at the detector. So basically you want a lot of radiation to make it to the detectors so that you can actually have a discernible image. So all of this is very important. So basically the grayscale image is displayed on a television monitor, a CRT, or a liquid crystal display. As this book is slightly old, we're going to take television monitor, cathode ray tube completely off. I highly doubt any facility is actually utilizing this. And we see here that the primary LCD has become the main type of display. Basically, and we no longer have basically gray monitors, but we have LCDs that are capable of reproducing color. That's why in 3D reconstruction we can utilize color. It's important that these displays have the optimum resolution to display. The display matrix can range from 64 to 124 by 124, but due to high definition coming about, we actually see that we have images now with 2048 by 2048 matrices. And so due to the increase in technology, CT has kind of utilized that as well so that we can have better images. So that brings us to windowing. You've probably heard this referred to in terms of looking at images. Someone referred to as windowing this image. And when we say windowing, the CT image is composed of a range of CT numbers, such as plus 1000 to negative 1000, for a total of 2000 numbers being in this field that represent varying shades of gray. The range of numbers is referred to as the window width, which controls brightness. The center of the range is the window level, or window center, and it controls contrast. With a window width of 2000 and the window level of 0, the entire grayscale is displayed, and the ability of the observer to perceive small differences in soft tissue attenuation will be lost because the human eye can only perceive about 40 shades of gray. Very important that the human eye can only do around 40 shades of gray. Can't do much more than that because everything starts tending to run together. And so here we have basically what things are on the Hemsworth scale. Bone or calcification, is around plus 1000. Congealed blood goes somewhere between 60 and probably about 500. Gray matter, on the other hand, goes around 40 to about 50. White matter, on the other hand, is slightly less dense and goes from about 20 to 30. Blood is just a little more dense than water, usually around 10 to 15 Hounsfield units, and water is going to be 0. Fat, on the other hand, is slightly less dense than water, and so it has about the density of negative 100, and then air is going to be at negative 1,000 Hounsfield units. And so this just kind of demonstrates to you where everything kind of falls and how everything, what kind of fits into this. What's kind of fascinating is where your organs actually lie. So your kidney is around 20 to 40. Your pancreas is going to be 30 to 50. Blood's going to be about 50 to 60. Liver is going to be about 50 to 70. Liver is going to somewhere be around where the pancreas is. Oh, well, let me take that off. Liver is up here. But you can also manipulate the Hounsfield unit to better demonstrate certain types of anatomy. We see here on bone windows we have a window center and a window width. The center is at negative 1,000 and the width is 2,500. Here we have a center being negative 50 and a window width of 400. And here we have a center of negative 60 and a window width of 1,700. And so as we can see, basically all we need to realize here is that different types of windows and levels can actually really affect what an image looks like. So the format of the CT image, the original clinical CT images were composed of an 80 by 80 matrix for a total of 6,400 pixels. The size of the matrix is chosen by the technologist before the CT examination and depends on the anatomy under study. The technologist must select the field of view or reconstruction circle. And so the field of view is going to really affect what you see. Because the slice to be scanned has the dimension of depth, the pixel is transformed into a voxel or a volume element. The radiation beam passes through each voxel, and the CT number is then generated for each pixel in the displayed image. The display field of view can be equal or less than the scanned field of view. And so here we have what an actual printout of the image looks like. As you can see, you have all different numbers. We have some that are less dense, kind of residing in this area. Then we have some in this area that are really dense. Then we have some that are just kind of in the middle here. And so it would be very difficult to discern what you're actually looking at here. And so because of that, that's why the computer has to process these numbers and really differentiate them for us. So in kind of wrapping up, the sequence of events of data flow is what we're going to look at. Number one, the X-ray tube and detectors rotate around the patient who is positioned in the gantry aperture for the CT examination. This step is characterized by the beam geometry and method of scanning. It involves the passage of X-rays through the patient. The X-ray beam is highly collimated by the pre-patient collimators. Number two, the radiation is attenuated as it passes through the patient. The transmitted photons are measured by two sets of detectors. Number one is the reference detectors, which measure the intensity of radiation from the X-ray tube. Remember, we've already discussed that we need to take a measurement from the tube and so that the detectors can see what has been attenuated. And so the reference detector is what does this. The image detector is what records the X-ray transmission through the patient. So it looks at the attenuation value, how much was produced versus how much has actually made it there, and then analyzes it. The transmitted beam and reference beam are both converted into electrical currents and then amplified by a special circuit. Number 4, before the data is sent to the computer, they must be converted into digital form. This is done by the analog to digital converter or digitizers. So keep these two things in mind. Steps 2, 3, and 4 are the second step in that data acquisition process. So basically, steps 2, 3, and 4 are going to be what takes us from acquiring the images to sending them to the computer. Step number 5 is that the data processing begins. This occurs when the digital data undergoes some form of pre-processing, which include corrections and reformatting. Convolution is performed on the data by the array processors. We'll get to this later, so don't worry about it. This will be covered later. Number 7, the specific reconstruction algorithm then reconstructs the image of the internal anatomic structures under examination. We'll get through to 7 later too. The reconstructed image can then be displayed or stored on a magnetic or optical tape or even CDs. The image processor shown in figure 421 allows the performance of various digital image post-processing operations on the displayed image. And so here's just something that's kind of going to allow you to see what goes on. You set your scan parameters. Your X-ray tube rotates around the patient to collect raw data. This is then transmitted through the detectors to the computer, which then pretty much does all of the rest. We see that you have reformatted raw data that is corrected then by computer software, which uses convolution and algorithms to actually affect and manipulate the image into something that is got acceptable quality. And then after everything is done and the mp4s have been reconstructed and volume rendering, the image then has to be displayed and stored. And so, as we can see, there's a lot of processes that have to go on for each CT scan. So that brings us to the advantages of CT. Number 1, there's no superimposition. You don't have to worry about that any longer. Also, excellent low contrast resolution. Images can be manipulated to suit diagnostic needs. Shorter scan times with higher quality images. This is what we have strived for, to produce high quality images that provide great assistance to the patient and the radiologist and any other physician that might be looking at these scans. And then do this with a shorter amount of time. The patient actually has to be inside the scanner gantry. And then to produce high quality images while doing so. Those are things that CT has really met and excelled at. But also, we now have the ability to manipulate these images so that the physicians can gain a better diagnostic quality and diagnostic value to them. However, that's not to say that there's not limitations in CT. The dose, which we'll discuss later, is still something that is very, very difficult to discern. We know that it's generally higher for similar anatomical regions than conventional radiography. But one thing that we have to look at is basically, is the dose justifiable? Is the dose something that we can live with based on the diagnostic qualities that we actually get from CT? Also, CT has difficulty in imaging anatomical regions in which soft tissue structures are surrounded by large amounts of bone, such as the posterior fossa, spinal cord, pituitary, and interpetraneous space. We all know that MRI does an excellent job of imaging the spinal cord, and situations like this is why MRI really has excelled and gained precedence in these areas. That's why CT just really doesn't hold a candle to some of these things. Metallic objects can cause streak artifacts, and so that's another important thing. Your EKG leads, things like that, have a tendency to sometimes throw scatter up, and because of these streak artifacts, it really can be sometimes detrimental to the image quality that you receive. And so many times these things cannot be avoided. I always think about scanning patients that have Harrington rods in their back, and if you do a chest CT or a T-spine, things like this, your images pretty much don't look good at all because you have such an enormous amount of streak artifacts that the images become quite unreadable. And so things like this really do cause difficulties in terms of CT. But the ultimate question and the ultimate thing to ponder is, are the benefits that we gain from CT enough to justifiably kind of not disregard, but allow us to justifiably utilize CT. We cannot disregard the dosage or some of the difficulties that CT has in processing images, but is it justifiable? And that is the question of the day, and probably the question for many years to come, as we see CT still growing in prevalence. What is the ultimate outcome?